You can hear me, eh?
Yeah, loud and clear.
Perfect. Today is going to be on pretty much, I've changed the topic a little bit. I think it's worth to just mainly speak about medial or medial knee OA and what we can do besides total knee replacements. So we're leaving out patellofemoral joint replacements, and we're leaving out things to do for the lateral knee. So, for example, distal femoral osteotomies for treatment of lateral OA. So we're just focusing on that. I think it's better because it just doesn't dilute as much. And I think speaking to the seniors, it looks like that's pretty much where the meat is and where they want to focus on. I've asked, I don't know if they're here, I've asked Ashley and Peter to prepare something, but they're not here yet. Now Peter is here. I think, Peter, what we can do is maybe you and I start chatting, and let's see if we can, what I want to do is actually, I want to argue with you, Peter. I want to say, you choose one other. What did I give you? HTO, hey?
Yeah, HTO and uni knee replacements.
Okay, well, which one do you want to have?
A uni knee.
You want to have a uni knee, okay? Let's assume he's 55. Peter, you've basically started your career as an orthopedic surgeon, but had a fantastic lifestyle as well. Your wife gave you enough time to play lots of tennis, and now you're starting to create this medial pain. You've got medial joint line tenderness, and you've got some pain there now. And I want to convince you to not have a uni knee. And I want to ask you firstly, so mainly I want to convince you just because of the outcomes, because I think the outcomes of uni knee replacements are terrible. Show your face, Peter. Why do you think I must give you a uni knee? I can.
Oh, can you hear me?
Almost. Yes. I can see you now, but okay. I can see you.
So go back to the question again. Why convince me to not get a uni knee?
I want you to argue. I mean, you say you want a uni knee. I want to know why.
I want a uni knee based on the fact that if I got anteromedial OA, I hear that it provides me a shorter recovery period, shorter length of stay. I'm going to be in the hospital tomorrow morning. I could probably leave the same day as well as a day case. My complication risk is a lot less. That's pretty much why I want a uni knee.
Okay, well, so you just wanna you're like a short-term kind of guy. You want to basically just you're worried about the perioperative the perioperative risks, but you're very young and healthy. I don't think you need to worry about that too much. So you're saying that you're gonna get out of the hospital quicker, and you're gonna have less deep vein thrombosis, and you're going to have less risk of deep vein thrombosis and wound issues. But are you going to really get back to your day-to-day and your sport quicker?
I think with regards to sports, I think high impact sports, probably not, no, unfortunately not. But with regards to lower impact sports, yes, I would probably get back to sports much quicker, yes, than a arthroplasty osteotomy. And so with regards to actually survival rates on a uni, based on National Joint Registry, is actually a lot higher than HTOs at the moment. There's not much evidence on that with regards to National Joint Registries on arthroplasty osteotomies.
Okay, well, that doesn't mean that they won't work. It just means that people aren't asked to put their data into a registry if you do a HTO, but with arthroplasty, you're going to have to put your data into a registry, and that's why we have better data there. So I mean, what you're looking at there? Are you what's your aim? How much? What are you happy with in terms of revision rates? At what time frame?
I mean, we're looking at about 10-year survival rates of about 80 or 87% in comparison to a total.
I can get you 70 to 80. I can get you 70 to 80% with the HTO at 10 to 12 years. But I agree with you. After that, so let's assume I can basically buy you 10 to 12 years with an HTO. But after that, you're going to have issues. You're going to start having a much higher risk of failure. But up to that time, I can get you a good 10 years of active lifestyle. I'm going to give you your native joint. I'm not going to take any ligaments away. I'm not going to take any meniscus or any cartilage away. You're going to have your native joint. I'm not going to take any bone away. You're going to preserve your bone stock. You're going to have much better range of motion as in the uni knee. Much quicker recovery too. I mean, we're talking about 3 months, you're back at sports. Don't you want to? Why can't I entice you?
I guess it does, but if you're going to be going for a revision, which may be sooner, I think going from a revision from a uni to a total knee replacement is a lot easier than going from a revision HTO to a total. Particularly becomes a more complicated and more difficult operation.
Okay, so let's assume you're going to have, it depends really how much I must correct you. You're right. I give it to you. It's a good argument. So I'm going to have to take out the plate first. Now I'm going to probably do HTO first through a medial or anteromedial approach. And then I have to basically do another midline approach for your primary total knee replacement. And so, yes, operations are a little bit more tricky, but I would argue that you have a uni knee, and if you want or need a revision for that, then it's not a straightforward revision where I just cut the tibia without any bone loss. So I might need stems, I might need some augments. So it's not a straightforward revision either. And actually, why don't I just give you a total knee replacement, Peter? The lowest revision rates.
This is true. But
primary total knee replacement much better is any revision from a uni knee or a HTO.
It's true. I mean, the survival rates of a total knee, you're looking at 94% in comparison to unis and HTOs. But unfortunately, you're not preserving generally your native bony anatomy, and you're not preserving that proprioceptive mechanism which you're ideally wanting. So actually, it's proven that your unis have a much better functional outcome, especially short-term, than your total knee replacements, and actually a lot less complications as well.
Okay. Yeah, so basically that's kind of what you want to argue in an exam. That's basically what and you can obviously put some numbers to it and some kind of bigger studies. If you really want to hit it home, you would maybe, give me a study that's a randomized controlled trial, or maybe give me a big meta-analysis. Have you got something like that?
Well, one or two things, mostly based on joint registries itself and the TopGet trial, which is unfortunately shorter duration. But yes, I've got some studies that provide that evidence.
Okay, tell me about that. What is that trial?
The TopGet trial was a trial that was in 2019, in comparison of unis versus totals, looking at functional outcomes. Unfortunately, it was only a 5-year duration, and they found no difference actually in functional outcomes between the two.
Okay. So they actually argue it doesn't matter whether you get a total knee replacement or a uni knee replacement. They're saying at least at 5 years. So if you want to look at short-term function, they have a tiny bit of better function, and it's a little bit less expensive. So they say that you have a tiny bit better life quality adjusted years with a uni knee in the first 5 years, and it comes with less perioperative complications. So they argue that because of that benefit, basically the physiological cost to you is less in a uni knee, and that's why they argue for it. And that's a trial that was published in the Lancet in 2019. So that's a trial that it's very nice to know, the TopCat trial. And then there's a few other bigger kind of registry-based data. But yeah, so in essence, I think that's pretty much. If anyone has another question to that or another comment to it, you can let us know. But that's what you kind of want to argue when you speak to a patient. That's kind of the discussion we're always having with the patients when they ask, should I do a uni knee, should I do a total knee, or should I do a HTO? And that's also in an exam what you could mention when you asked about outcomes and how to predict outcomes. But thanks very much, Peter. That was good. And I don't know if Ashley's still here, but you've pretty much done what Ashley needed to do as well. So is there any questions? No. Let me start with the HTO first, and then we go to the uni knee, if that's okay with you guys. I think you can see everything now.
My name is Michael Held, and this is a talk for the...
Oh, man. I need to actually play that without the recording. How do I do that? How do I do that? I almost have to show it to you like this. Is that okay?
Yeah, it looks okay.
Has to be.
Yeah.
Okay, cool. So unless you want to listen to my monotonous voice on a recording, but you can just listen to my live monotonous voice. Maybe that's even more monotonous.
Can't you mute that little speaker icon in the bottom right over there? If you click on it.
Yeah, but it'll click on, I think, as soon as anyway, I'll do it like this. Okay, so the question is this: is this a good patient for an HTO? She's 55 years old, he's active, he's a smoker, give it to him. He's a little bit heavy, 82 kilos, and his conservative management failed. What do you guys think? Ahmad.
Mark of the problem.
Hey, can you hear me? Hopefully. You guys can hear me, eh?
Yeah, I
yes.
can hear you.
So Ahmad, what do you think? Is this a good patient for a unicondylar knee replacement? An HTO.
Yeah. So 55-year-old active smoker.
Yeah.
With conservative management has failed. So on this AP, we only have one view. So only have an AP, an AP X-ray. He does predominantly look like he's got anterior medial OA. We'd need other radiographic images as well as examining him clinically.
Good. Okay. Just
But
based on
you
the
asked
information you have now, where are you leaning towards?
So I'm leaning towards a unicompartmental knee replacement.
And based on what?
So just based on his anterior medial OA, so based on his distribution of his arthritis.
Well, the distribution of the arthritis, it's always going to be anteromedial because that's the topic of the day.
Yeah.
But you're gonna have to decide based on the severity of this.
So that's bone on bone.
Yeah.
Yeah, so that's bone on bone, and for that, the best treatment would be a replacement of that compartment.
So you're right. I mean, many people do HTOs for this, but the outcomes are more predictable for unicondylar knee replacement in this case. Plus, he's a smoker. You don't really want to do an osteotomy. It's a relative contraindication it's a relative contraindication for that, for HTO. So a good patient is someone with all these attributes here. That's a perfect patient. So if you find that patient, then go for HTO. Someone that's active but not too active, someone that doesn't do jumping or cutting sports. It's kind of in the 40 to 60 year age group, and it's got isolated medial compartment problems, but has got fairly good function, range of motion, good stable knee, and it doesn't have too much of a alignment issue. So that's a perfect patient for you to do an HTO on. And this guy is not a winner. So a smoker and bone arthritis is not great, but also looking at other things like inflammatory arthritis, both for HTO or uni knees are not, it's a contraindication. And then the malalignment issue is if you have more than 15 degrees of malalignment, you can still go ahead and do a HTO, but it becomes more complicated and it's more risky to do it. So that's why people kind of shy away from it a little bit. But it's certainly possible. And then eventually you'll get to a point where you're going to have to figure out if the joint line becomes oblique by correcting it. If you have a great a big angle of correction in the tibia, you might actually have you might not parallel to the ground anymore. And then range of motion is something that affects both the uni and the HTO, so it's not specific to one, but it just it really decreases the ability to do the surgery well, but also to have good outcomes afterwards. So that's not a winner. So we really want to look for an HTO. We really want to look for these young patients that are kind of have a good knee and just starting to have early medial OA. And then you'll have that 10 to 12 year time window that you can buy them with an HTO. So this is one of the patients that we found that is like this in our clinic. And he was actually, last week, he came for his follow-up. He had that was 3 months down the line. So he's a 45-year-old male. He had 5 years, he's 5 years down the line from an ACL revision. So he previously had an ACL, then re-injured or basically failed that initial ACL reconstruction, and now he had a revision, and that revision also failed. So he's got this medial OA. You can see we did a MRI scan, and he's got some thinning of the cartilage, but it's still okay. And he's got this meniscus that's pretty much almost debrided or very degenerate. So although on the other side, on the lateral side, he's actually got a very good joint. So that's a nice patient to go and do. And you're right, we need good workup. And these are the things that we ideally want. The straight leg, the mechanical axis views, the Rosenberg views. We chatted about this in the meeting before, but the Rosenberg views are in 45 degrees of flexion. So what they do is they basically show you different parts of the femoral condyle, and they show that to you as looking straight into the joint. So when you have the knee straight, usually with the posterior slope, you can't really see orthogonal into past the tibia. So Rosenberg view really shows you that. Plus, it shows you a little bit more the posterior condyles, or the a transition from the distal to the posterior condyles. And if there's arthritis in that area, you can't really see it when the leg is fully extended. And then if you don't have an MRI scan, stress views are quite nice because they can help you to determine whether the lateral side is still got good cartilage or not. So in this case, so this is our patient again. He has, in him, we saw indications for surgery. And these are actually the indications that are taught for HTO. And these are quite important to have in mind when you think about an HTO. So obviously, you do it for someone that has got an isolated compartment disease. But that can be either the cartilage, it can be early arthritis, or it can be subtotal meniscectomies that are now becoming symptomatic. And so that is basically the early parts of arthritis, or in the early beginnings of the arthritis. So if it's established with bone-on-bone arthritis, you want to really go and think more about replacement. And then the other thing is the ACL failure that he had. You can actually adjust the slope during an HTO, and I'll show you later on how to do that. But the slope is directly related to the risk of failure of an ACL reconstruction. So the further you slope, the higher your slope is, the further you have a risk. And the cutoff point is usually about 12 degrees. So 10 plus minus 2 degrees is the norm. And in someone with an ACL revision, 12 is like the cutoff point where you need to really consider doing some form of osteotomy to reduce the slope. We don't really know what the varus does to the ACL reconstruction. People have really looked at it and tried to figure out whether varus alone creates ACL risks to failure of ACL reconstruction, but they're not completely clear on it yet. If there's bone-on-bone exposed, or if there's bone exposed, the cutoff for where you say, okay, well, actually this needs more than an HTO is usually about 1 to 2 centimeters squared. So once that area of denuded cartilage is bigger than that, you'd have to think about other things. And this is not really got to do with arthritis, but if there's ligament laxity, in this case, if you had in a varus knee, if you had a LCL that needs to be reconstructed, we'd have to really think about doing an HTO first before we do the reconstruction of the LCL. But that doesn't have anything to do, it's just an additional indication for an HTO, but not in our case, not in this patient. So he's got a mechanical medial patellar-tibial angle, medial proximal tibial angle of 5 degrees. And so he's basically got most of his varus, because his hip, knee, ankle angle is 5 degrees. Most of his varus is actually in his tibia. So by correcting his tibia, his tibial varus will correct his overall alignment pretty much to neutral. Okay, so this is just to explain why the slope and how it affects ACL reconstructions. It's basically the higher you make a slope. So if you increase the slope by 10 degrees, you translate in the lab setup, you would translate the tibia by 6 millimeters. And so it does start to stretch the ACL if you increase the slope. So what we actually want in the HTO, and specifically in this patient, is we want to decrease the slope. So now the next question is, well, we've got this workup now. How do we actually do that? How do we plan the HTO? The HTO is basically it has kind of, it's been around for a long time. Osteotomies have been around for a long time, but really in the last 20 years have people started to think about it more systematically and have created workup plans, and the instrumentation has improved and the implants have also improved. So it's really kind of become a new technique again. Although we knew it from the past, it's become a new way to treat people again, that surgeons fall back to. So one of the main things is to really understand how to plan it. And there's various ways. This is the Mignazzi technique, where you draw a mean axial deviation from the hip center down to the ankle center, and you see where it transects or crosses the knee. And then you actually want to draw a line from the hip to where you think it needs to go through the knee. And we'll go through that just now, where we would plan that to go through. There's a specific way to look at the knee preoperatively, but also intraoperatively, to decide where this mean axial deviation should go through, or this axis. And then you'd come out with a point distally where the ankle should be. And now, as a second step, you need to figure out where you're going to hinge the osteotomy. So the hinge point is usually the best way to figure out the hinge point is when you look on an overlapping AP image, when you see the tibia and the fibula head overlapping, that point where they overlap, the most proximal point of that is actually a good point to aim for. And that's usually about 1.5 centimeters away from the joint. That spot is basically where the cartilage, the cortex is quite soft and can bend with the open wedge. But it's also enough bone proximally to make sure that it doesn't fracture into the joint. So obviously, the further distal you go, the harder that cortex becomes and the more easy it is to get a hinge fracture. The more proximal you go, the more risky it is to actually fracture into the joint. So that's a good point. And from that point on, we can then draw an angle that goes basically that establishes the angle from the ankle where it is and the ankle where you want it to be. And so that alpha, what you see here, that angle, you can then translate onto the tibia. And there's a trigonometric chart that you can then decide on by measuring the distance of one of these of your osteotomy length. By measuring that distance on your X-ray and by knowing what angle it is, you can then kind of calculate based on this chart how much you need to open it up here. And that gives you then a good kind of aim of where you want to, during the surgery, it's another check for you to say, okay, well, I want to have a 10-degree open wedge. I've got a 55 millimeter osteotomy length, and so I have to open that cortex by 10 millimeters. It turns out actually that it's more or less a thumb suck. Is if you want to open it by 8 degrees, you usually open it 8 millimeters. If you open it by 10 degrees, you want to open it more or less 10 millimeters. So, but this chart, obviously in the extremes, it'll give you different numbers, but most of the patients that we operate, it's a thumb suck that you can use quite easily. And that's basically how you would plan for it, for the osteotomy. The main thing is that you want to know how far you need to, where do you need to put this center of the knee? Where do you want to aim that this corrected Michelitz or line goes through? And so what we have is we have a reference point which is called the Fujisawa point. And the Fujisawa point, he basically calculated based on his cohort of patients that if you wanted to have a 3 to 5 degree valgus in your knee, that you would have to go through a point that's about 62% away from the medial part of that entire width of the knee. So basically, if that line, if the Michelitz line goes through 62.5% on the lateral side, then you know more or less you'll be at 3 to 5 degree valgus. And so that's why we use that as a reference point. But in essence, if there's a lot of OA in the medial compartment, you aim a little bit further towards the lateral side. If you have good cartilage still left, you want to aim a little bit more towards the midline. So it's not like set in stone, but ideally you can kind of see that if this line goes through that downward slope of the lateral eminence, you're usually in a good spot. So that's what we want to have as a reference point, and then we just need to figure out, obviously, the joint line congruence angle. That plays part in the overall correction as well. Obviously, if the the axis is inverus, that angle is usually open, but as the leg corrects and you correct the varus, usually the joint line conversion angle also disappears. And so you need to take that into consideration and potentially subtract from your original planned angle of correction this joint line convergence angle, sorry. So that's something that we just need to keep in mind. So this is pretty much what we need to know about planning it, in terms of the the pre-op workup. And then I'll tell you about the technique quickly. So it's usually a meter-based incision about 8 centimeters from the joint line going down or distally. And then we hit the superior border of the pes, which is here. And that pes, if you lift it up underneath, you have the MCL. Pretty much the same as when you plate a medial condyle fracture, a medial tibial plateau fracture. And now you can actually release the superficial MCL down. The deep MCL is attached superiorly, but the distal part of the superficial MCL you can release, and then you can apply the plate quite nicely, and you can find the osteotomy site and really be able to take the saw into that area. You need to strip the MCL of the bone. Then you mark the area where you want to make the cut, and it's usually about 3 to 3.5 centimeters from the joint line, because you need enough space to place screws up there. And you put in a wire, and you put in another wire right underneath it, and then make sure that those two wires are completely superimposed in an AP X-ray, so you can see this the tibia head on, and you know that these two wires are perfectly superimposed. That means that you've aligned your plane of osteotomy to the joint line, and it also means that you can now make sure that you don't create any issues with the slope by cutting this basically in the same plane as your joint. If you don't do that, then you can create issues with your slope. And then you make sure you put in Holman retractors before you start doing the osteotomy. So that's the osteotomy. And then this is basically from the Tomofix surgical technique. I've just taken that out because it's just nice to see. There is basically a biplane osteotomy where we cut through the tibia first, and then you cut up so that the tibial tubercle is not, you can't cut through the tibial tubercle, otherwise you'll hurt the patellar tendon, or you damage it, or you're at risk of damaging it. So you can either do the biplanar cut towards proximal or towards distal. If you do it towards proximal, the patellar tendon stays attached there. And so when you do that, then you actually, by opening up the wedge, you actually move the patella down. So you get patella bia here. And that's obviously a problem because in a patient that has got quite a bit of patella bia already, you might reduce flexion in this patient and they get anterior knee pain. So that needs to be just evaluated before the surgery. And in someone that's got very low patella, you might actually want to draw that, do that osteotomy distally. And then you start to open it up. So initially you put that saw through until you're about 10-15 millimeters away from the hinge point. Then you take osteotomes and you push those osteotomes a little bit further, and you slowly open it up over time and with a laminar spreader until you have the desired amount of opening. And then you can put some bone graft in there, put the plate on. And then if you look at this, how on this image here, the plate is basically sitting anterior to the laminar spreader. That means the opening is not rectangular. The opening, when you look at it from medial, is a lot less in the front than is in the back. And that's basically a check rein for you to make sure that you don't increase the slope of that patient. So once that is done, then you can check with the cord of the cord tree. You can check from the hip down to the ankle. And it's usually a little bit crude, but you can then, it's another check rein for you to make sure that the hip, knee, ankle axis, it goes, the Mikulitz line goes through the desired point. And this is basically what we've done for this patient. So he's got now, you can see the line goes through the middle of the knee. Unfortunately, not as much to the, we could have maybe taken it a little bit more lateral. And we've reduced the slope by 5 degrees. So he's now in a position where he's pretty much pain-free. So he doesn't actually have pain medially anymore. Plus, he doesn't feel a lot of instability. Although he doesn't have a ACL, he's actually decided not to have the second part of the operation. So in him, it actually worked very well, not just for the pain, but also for the instability. And then there's always a question about rehab, and there's been some randomized controlled trials where they did full weight bearing versus non-weight bearing, and it didn't really make a huge difference. The main thing is really if you break your hinge. So if that hinge point on the lateral side is fractured, it becomes a lot less stable. And the way you can actually see this is if you look at the AP X-ray and you see a double line in your osteotomy site. So if you can't look at it, when you oh, I wonder if I've got an X-ray like that. No, okay. If you don't have if you have a double line on the distal and proximal osteotomy of the tibia, then you know that you've probably fractured your hinge because you're actually opening it up instead of in the front. It's too complicated. Anyway, it's too complicated to explain here without an image. So basically, if you fracture your hinge point and you figure that out, that you fractured the end point, it's better to protect weight bearing for 6 weeks. And that's basically, we've spoken about that. Outcomes, return to sport. We've spoken about that with Peter. And this is just something, so I want to ask you guys, why do you think that most people do open wedge osteotomies? Maybe Brad Bonner.
How's it, Prof? From what I read, it sounds like just because you have more variability intra-op, so your cut doesn't have to be as precise. With a closing wedge, you've got to have an exact cut and close it down, and that's what you've got. With an opening wedge, you've got some more play to try and correct what you want to intra-op.
That's right. And why do you think people have moved away more, or why are more people doing opening wedge? I mean, it's not too complicated to plan your osteotomy properly, and you can just do a closing wedge.
So there's a few complications that you can get away from. One of them being the peroneal nerve, if you rather do an opening wedge as opposed to a closing wedge.
Yeah, that's right. That's one of the problems.
Other than that,
so you obviously need to do a fibular head osteotomy. So it's an additional step. Plus, it's obviously some there's some impact on the knee, and the other issue is that it's a little bit more tricky in a closing wedge to do a conversion to a total knee replacement than in an open wedge.
Bone stock, yeah, that's it, yeah.
And it becomes a shorter leg in essence. So The open wedge osteotomy doesn't do that. And the reason why people are doing it more and more is because we've got much more stable implants now than they had a couple of years ago. 20 years ago or 30 years ago, there weren't any locking screws or locking screw plates available. And so with a very stable implant, it becomes a lot less, there's a lot less implant failures and non-unions. And that's basically the advantage and the disadvantage. The main thing really is the union is faster. It's not that there is more union or non-union rates with open wedge, but it's just faster with a closing wedge osteotomy. Okay, cool. And then, so that's that. Yeah, then the issues, mainly what we always worry about is fractures, especially during surgery. So the key is really to plan your hinge point right, so that this hinge point you can see on this image here is, if that hinge point is stopping, if it doesn't go all the way through to the, if your osteotomy doesn't go all the way through to the cortex, or if your hinge point is too proximal, then by levering it open, you start having a high risk of this intra-articular fractures here. And those are I think those are the main issues around fractures that are acute fractures. And then the other issues, if you over or undercorrect, then you get problems either in the medial compartment. If you undercorrect, it's not really going to make it a whole lot better. Or if you overcorrect, you get problems in the lateral compartment. And the other things here on this side we've spoken about. So besides the non-union and the fractures, this under and overcorrection is probably the most common issue with HTOs. Cool. I mean, that's pretty much the HTO talk. The revision challenges we've spoken about. The bone loss in the unicondylar knee replacement is quite severe. And in osteotomy, the issue is that you have to take the plates and the screws out first, wait for the wound to heal again, and then come back to do the total knee replacement, which can be quite challenging if there's bone loss. And obviously, you've got issues with soft tissue and scar, the planning of the incision with a previous incision made medially. Cool. So that's the uni knee. Is there any questions? Do you guys have any questions? No questions.
The only one I was wondering, Prof, with that, and you're correcting your posterior tibial slope intra-op. Do you just eyeball that, or how do you measure?
Yeah, it's not easy to figure out exactly, especially not with the HTO. Some guys just do a slope reduction osteotomy, and then you can plan it as a closing wedge osteotomy anteriorly. You can plan it exactly, similar to the closing wedge as tibial osteotomy on the lateral side, but in the HTO, it's not easy to adjust and measure the slope. You can obviously take a lateral X-ray and then gauge it. Maybe with an iPhone app, you can probably even measure it. But it's not as easy as it is to correct the varus. That's true. Any other questions?
Hey, Prof, it's Johan speaking. I just want to know your example that you gave us about the young patient that came in after the revision of the ACL that you said was a good candidate and that went on having the HTO later on. Do you think initially it would have been a good idea to consider doing an HTO for him at the same setting, or also, like you said now, a planned HTO following with ACL recon following, just to consider more addressing his posterior tibial slope as well, decreasing that so that you have that protective element protecting your ACL graft? That's number one. And then I also just wanted to know, with your biplanar osteotomies, in the light of instability, whether ACL or PCL. Is that also, I just read when you have the combination injury, it's also quite relevant to aim for a neutral slope, because in the one light you'll have your ACL that wants less of a slope, and then your PCL wants more of a slope. So when you've got that combination injury, rather aim for your neutral slope. Yeah, I would just like your thoughts on that.
Okay, so it's like when a question becomes a comment. Let me just try to filter out. So I'm going to show you quickly this slide, just a second. Osteotomies. You can see this now?
Yes, Prof.
Okay, cool. So let's go see if I can find this again. This is the case. So I think this one here. So the question is, so let me start with the second question you had. You basically asking me, what should the slope be if there's an ACL and a PCL instability in this knee? So usually you have a chronic knee with the ACL and PCL instability. A chronic knee instability means at least 6 weeks since the time of injury, and then you've basically had a look at this X-ray and you decided, oh, there's a big decrease or increase of the slope, and you want to adjust that. And that is a very unusual case, because normally what you would have had is either ACL or a PCL injury. And in a case where you have done an operation and something fails, it's usually not the ACL and the PCL that's failing, it's usually one or the other. So if you have a patient that has failed his ACL reconstruction, he comes back to you with an increased slope, then you think about decreasing that slope. If you have someone that has failed his PCL injury and has got a inverse slope, so almost like this one, then you consider doing an increase of the slope. These are such rare cases, that we don't. I mean, we are looking more and more at this increased slope in ACL, but it's such a rare case. I mean, there's maybe 1 or 2 cases a year that high volume surgeons are doing for the ACL. That to do that for the PCL is almost, I mean, very, very, very unusual. So it would I haven't done a slope surgery for a PCL, a chronic or failed PCL injury. It's an interesting concept to me, but I haven't done it yet. And we're doing quite a lot of PCL surgery, so maybe I must look at it more and look at the the failed PCL injuries and decide on it. But I guess I wouldn't fiddle with the slope unless it's really, really necessary, because it creates a lot of issues as well. For example, if you decrease the slope, you're actually causing hyperextension in the knee. In a knee that looks like this here and it goes basically straight, if you decrease the slope, but whatever you decrease it, you'll also increase the hyperextension. And the same with not getting into full flexion if you decrease the slope. And what was the first question?
It was just that same example that you gave. I was just wondering if considering doing that H2O earlier with the ACL reconstruction, it would have helped him not to have had the revision now subsequently.
Yeah, obviously, at that time, this whole slope thing, only really hit home in the last 5 years or so. So beforehand, we didn't really consider it as much. So yes, it would have probably helped, and we obviously now we do in any failed ACL reconstruction, we look at the slope from the start, and we consider doing slope reduction surgeries for that. Yes, definitely. The question is would you do a slope reduction and an ACL reconstruction at the same time? Because it's, number one, quite a lot of surgery. Number two, there's quite a lot of hardware. So, where are you going to put the ACL tunnel in something where you want to make sure that the osteotomy heals. So there's not a lot of space there. So people are doing it staged often. Okay. Can we go to the next talk, or is there any more questions? Okay, let's do that. I'm going to share uni knees. Okay. No. So you see the uni knee talk, am I right? Now I can share it like this. Happy with that?
Yep.
Okay, good. Let me just make sure it's the correct one. I hope this is the correct one. I hope this is the correct one, guys. Okay, cool. So this is basically a uni knee talk, but it mainly plays on how to select patients and how to plan the unicondylar knee replacement. And we know that you guys in the clinic, you see probably more complex cases, more advanced arthritis, and in the early stages, usually these patients don't really come to us. They either are treated in the periphery, or they come to us quite late. And so there's a spectrum of disease that is probably lopsided in our practice towards the more complex cases. And that's why it's not easy to have a good practice in unicondylar knee replacement surgery in state. The other thing is also, it's not easy. The learning curve is not a steep learning curve. It takes a little bit of time. And there's quite a lot of things that can go wrong, similar to a total knee replacement, but there's specific things in the unicondylar knee replacement that can go wrong. But the most common things why it fails is that the lateral compartment starts to degenerate, and that's usually at a later, like 10, 15 years down the line. And the more acute problems are, or the more earlier problems are, that the components fail, they get loose, and very basically perioperative problems are fractures of the medial. Usually it's of the medial tibial plateau, either by a stress fracture or through a pin that's been placed there to keep a guide, or basically by hammering the component into the tibia. And the dilemma is that we are trying to chase a number. So when you start off doing surgeries, UKA surgeries, or partial knee replacement surgeries, you start off trying to reach a number where you feel comfortable. And we know that the further the more cases you do, the more comfortable you get, and the more safe your surgeries become, and the less revisions you have. So a good idea is the UK Joint Registry, but also various other programs and studies in the UK have shown that high volume surgeons have a survival rate of 95% at 10 years, which is 10 years, the implants that were 10 years ago. So the implants now are obviously a lot more, or have been more advanced, but the implants that we had 10 years ago are still in 95% of the patients of the high volume surgeons. And if we want to decrease a risk to a revision of 1.6 times, then we need at least 1.6 times. We need at least 23 cases per year to be able to get a good learning curve. So we need at least 25 cases before we start becoming safe surgeons, and per year we need at least 25 cases to be able to maintain that skill. And that's why it's a little bit tricky for us, especially if you have a lower volume knee replacement practice, to be able to operate enough uni knee cases to be able to provide a safe surgery skills. So that means if you convert 25% of your knee if you make 25% of your arthroplasty cases uni knee cases, you need to operate at least 100 cases per year. And what's interesting is that once you're comfortable with the manual technique, that if you want to navigate a unicondylar knee replacement, that means with a robotic surgery or navigation assisted surgery, then your plateau is your learning curve is much slower, much less. In 6 cases, once you're comfortable with using it manually, it actually becomes a lot quicker to do robotic surgery. So in our case, we need to figure out if we really want that number, if you want to chase that number, is we can either increase our volume. So instead of operating 100 cases, we're going to operate 300 cases. And then we're going to get to 25 cases, even though we don't have a huge amount of conversion of the ratio uni versus total knee replacement. Or we become more aggressive in our indication. It means cases that you have normally decided to do a total knee replacement on, you now start to say, no, let's do a unicondylar knee replacement. And that's pretty much what's happening in our state practice, is that we are starting to operate a lot more cases that we previously would have said, no, this is a total knee replacement. We're starting to operate more and more of those and putting in unicondylar knee replacements. And that needs to happen in a safe way. And that's what I want to show you now, is how can we choose the correct patient for that? Because if you overshoot the mark and you become too aggressive, you obviously have earlier failures and then shoot yourself in the foot or the patient. So this is pretty much a slide that goes for any arthroplasty patient. That's kind of the general evaluation that one needs to look at. Symptoms. Then is the patient safe? So the comorbidities, what does a patient expect? And then what are the perioperative risks? And based on that, you can kind of figure out or hopefully predict what the outcome will be, what helps you to choose the correct patient. So these things here, high intensity knee pain is important. You need that, otherwise you can't make that patient better. If the pain is if there's pain elsewhere, you have to make sure that the expectations are that this pain is not going away. If there's poor mental health, doesn't really give a boost to your outcome. And then this pain catastrophization is a big topic at the moment that also plays into the outcome. So it's a very structured approach to it. Exclude inflammatory causes of that arthritis, look at the gait, look at the mechanical alignment, range of motion, laxity. But I want to focus on the radiological assessment because it's the most objective way to select your patients. So we decided, and Ahmad was right, it's bone-on-bone arthritis, and bone-on-bone arthritis does very well. And it's actually one of the main important features that you need to see in your patient if you want to do an arthroplasty. So whether it be total or uni arthroplasty, you need bone-on-bone arthritis to have good predictable outcomes. So that's the first thing. Then we spoke about HTOs and the contraindications for HTOs. It's similar in a unicondylar knee replacement, except that inflammatory arthritis, overweight is not a problem anymore. That's been disproven. And also, people were initially worried about young patients. And obviously, the younger you are, the higher it is to have in the future, to have a revision to a total knee replacement. But it's also that that should not be seen as a contraindication. And we have very similar limits to the surgeries compared to the high tibial osteotomy. There is a fixed flexion deformity of more than 15 is a problem, because the ACL starts to stretch out and potentially become ACL deficient. The knee becomes ACL deficient in the future. So it's something that is not ideal. And flexion less than 90 is a problem, because you can't actually do the surgery, because you can't release like in a total knee replacement and get into the joint properly. In someone that doesn't have 90 degrees of flexion, it's very tricky to do this operation. And the others are similar as for the HTO, except, for example, in the HTO, you would probably accept the ACL deficient knee, because you can do that in a separate setting. You can first decrease the slope and then decrease the varus, and in a second setting, if the patient is still unstable, you can do an ACL reconstruction. The same goes also for the unicondylar knee replacement. You can also do that single stage, or you can do it as stage surgery, ACL reconstruction, and uni knee. So it's not really that much of a contraindication anymore. So what if the patient doesn't have bone-on-bone arthritis, but is very sore? Now you have to figure out: must I try to convince this patient not to have surgery, or should I chase? Am I maybe missing something? So in a patient with an open or maintained joint space, you can actually do various stress views to see if it closes down on that side. And the Rosenberg views are important. We said that it often there's maybe a little bit more posterior the wear in the femoral condyle, and then you can see it closing down on the Rosenberg view. And if you're really unclear, you can actually scope the patient before you do the surgery. And if you see that there is good cartilage there, you must just tell the patient, look here, if I see cartilage, then you can't have an HTO, because I'm not a uni knee, because I'm not going to really have good predictable outcomes with it. So then they will just have to accept that. But many surgeons actually do scopes before they do the uni knees. And the other thing is, on the lateral side, on the lateral X-ray, you can see, you can look at the wear pattern. So the wear pattern should actually, this uni knee is made for anterior medial arthritis. So once the arthritis starts to drift more posterior medial, what happens is the tibia starts to move forward, and then the ACL starts to attenuate. So it's important on the lateral X-ray to actually look if there is a posterior erosion or posterior wear on the lateral on the lateral side, on the lateral X-ray. So in this case, didn't. That's a good lateral X-ray. So this, for example, these are this is what you would see, an erosion basically on the lateral X-ray. Posterior erosion would worry you. And this is again the anterior medial wear. You can see here that's how it looks like when you cut that piece out. So there's good cartilage in the back, and anterior medially there's wear. And then an MRI scan is obviously a very nice way to check, but it's expensive and time and cost intensive. It takes you 3 months to get an MRI scan, at least 3 to 6 months. No, so that's what we do. We do the lateral compartment checks we do with stress views. So a stress view shows you that the MCL is not, or the medial structures are not, can be stretched and the varus can be reduced. But it also shows you that the lateral compartment doesn't collapse, or that there's still good cartilage there. And this comes from Oxford. There's a big series that they've done all stress views for, and then they compared that to the outcomes, and they basically have created a decision tool that is based on these lateral or on these valgus stress views. And that's backed up with lots of data. So in their case, they basically argue that even lateral osteophytes don't really matter. And what matters is that there's no more joint space on the lateral side, and then a total knee should be done. The same for the patellofemoral joint. Pain, anterior knee pain, does not affect the outcome. So if you ask your patient, do you have pain underneath your kneecap? It doesn't matter. And also what doesn't affect the outcome is bone-on-bone arthritis, which is very, for us, initially we used this as an exclusion for a unique knee replacement. We said to ourselves, no, we can't do uni knees in a patient that has got bone-on-bone arthritis. And so all of this medial or lateral bone contact is not a problem for these patients. What's a problem is once there's complete bone loss or grooving, then we start having issues with patellofemoral tracking and pain. And so this is not an exclusion to a unicondylar knee replacement. And the next thing is what we can do now on these x-rays is we can measure the mechanical alignment. And usually the constitutional varus is about 3 degrees. So this case that I'm showing you now, it's got a 3 degrees varus in the tibia. And on the lateral x-ray, the varus in the tibia, what we do there is we basically, because we can't release the MCL, we almost consider also dialing in the 3 degrees of varus, or giving a little bit of varus when we implant the component. So many components or prostheses that are available have been tested and have been okayed to put in a little bit of varus. On the lateral x-ray, we look at the patella to make sure we can get in. So if it's a patella bia, then it's more difficult access. And we look at the slope here because it affects the tightness and flexion. So obviously, if there's an increased slope in this tibia, I'll take that away when I cut. And then later on, if I put less slope in the tibial component, then I'm going to have an increased flexion gap. And it's quite important to understand, to see if that knee actually, you can't release soft tissue, so you have to make sure that you can put the component in without disturbing the soft tissue, and that's why this is also important here. Okay, this is the second case. I'm not gonna bother you with. The main thing for the surgery setup is that you have a total knee replacement in the operating room. So in the back room, if you struggle, or if there's a problem with the set, or if you have issues if you think that there's more damage than usual, then you can just convert to a total knee replacement. And the setup is quite similar to a total knee replacement, except that you need to obviously look more from distal, because you're looking inside the knee through that area. And these are all the things that we've spoken about with Peter. So basically the main points is you need to pick a good winner So that means that you need to pick a good patient. It means someone that's fit for surgery, the expectations are aligned, there's bone arthritis, and you've done your stress views. You're happy that the lateral side is intact and that the patellofemoral joint doesn't have bone loss. And you just need to make sure that you've got some instruments in the back to and the total knee replacement in the back of the room in case you need to convert. Is there any questions to that? Do you guys have any questions? Yeah.
Prof, I was just thinking that it's more of a kind of pipe dream or a experimental question, but has anyone looked at doing a compartmental knee replacement with osteotomy in combination?
It's actually interesting that you say that. They are doing that now in the UK, and I know this because I had this request from a patient that had a severe varus knee, and they offered this person an HTO. So he had severe varus knee arthritis, and they basically offered him an HTO and a unicondylar knee replacement on top of it, because you obviously through the HTO they correct the mechanical alignment, and it allows them to have good soft tissue balancing, and through the unicondylar knee replacement they give a new joint space that basically gives him a more predictable long-term outcome if he's got bone arthritis. So they are actually looking at it. It's an interesting question, and it's not that far out. I mean, there's some crazy people out there, and maybe in the future it'll become mainstream. But at the moment, I mean, I looked at it and I couldn't believe it. But then I read up on it, and yeah, there are many surgeons that are looking into this now. Yeah, good question.
Prof, I've got a question.
Yeah, no, okay, thanks, Rob. Yeah, I assume it's technically quite difficult, and we obviously don't really have enough data on the outcomes. So
yeah, it's
we'll see where it goes.
Yeah, it's the same for people that are doing a medial and a lateral unicondylar knee, a medial and a lateral uni knee. So it's a bicondylar knee replacement in patients with medial and lateral OA, because they argue that you leave the joint, the native ligaments and everything is the same, and you can argue for it, except that maybe the cost is crazy because you're doing two.
So that's where I was going to ask, Prof. So just reading these studies, they don't clearly say when they talk about revision of uni to total, do they lump in there when some surgeons would add a lateral uni to a medial? Do they put that in those groups of revision? Because then for me, that doesn't really come across as a revision, just a progression.
Yeah, that's true. And it really is a very heated discussion always when people mention this in the in the conferences, because the one says no, but the uni knee surgeon says no, but that's not a revision. It's you can see it in the data. In 15 years, you got a 20% chance of having lateral sided progression, and if that's the case, then I'll just do your lateral side. Whereas someone that is leaning more towards a total knee replacement that doesn't have any revisions at 15 or 20 years, they'll say, well, now the patient has undergone another surgery. So I don't know, it depends on how you want to look at it. I guess you should say unplanned surgery. How about that? Because then you can say, if you get a lateral sided wear in 5 years, you would then consider doing an unplanned lateral uni, whereas in 15 years or 20 years, that would have been a predicted outcome.
Yeah, exactly.
My question to you is this: is what would you do? Would you want to have in your knee? Would you say, you know what, why don't you just pop in a lateral uni knee, or would you say no, rather just take everything out and do one thing, just do a total knee replacement?
I'm a firm believer in you must get your good years in while you're young. So go for it, use it up, and then if the knees are done in the end, then drop your sports and do something else. But go for it and get the good years while you're young.
Yeah, okay. I'll remember that in 30, 40 years from now, Brad, when your knees are
Take
done.
golf on the golf cart or something when you're old.
Okay, any other questions? No. Okay. I've got one more video now of a unicorn knee, how we do it, but it's about 10 minutes long or so. I'll just play it. You guys don't have to. Let me see if I can play it. I need to. This is basically just the technique now. Share my screen. See if I can play. So if I play it like this, can you see it?
Yeah.
But you can't hear it. Okay, well, then I'll have to talk over it quickly. The steps are the same as for the total knee. And then the main thing is really that we want to maintain a soft tissue tension. And the other thing is also that we want to have sufficient contact surface to make sure that the pressure that goes through the components is transferred as a compressive force to the bone underneath, so that you basically don't want to have shear forces. The same as in the total knee, but in the uni knee it becomes quite important because the surfaces are smaller, and so it's a little bit more tricky to ensure that. So it's a meter-based incision from the proximal pole of the patella down to the tibial tubercle, and we start to dissect down. The dissection, the key is really to open up a little bit proximally and incise a little bit of the VMO there, so that we can push the patella lateral, and that gives you a good exposure. And then on the meter side, we basically just take the osteophytes away. The osteophytes are basically the ones that are underneath the MCL, are the more important ones, because they give us space and they allow us to correct the varus. And unfortunately, we can't really release the MCL too much because we don't want to disturb the soft tissue sleeve. So we really have to work on the osteophytes. Same is done in the notch, so that we give the ACL a little bit of space to breathe, so it doesn't get constricted over time and pinched. And then we have this, similar to the total knee replacement, we've got this AIMA, a device that shows us where the mechanical axis is, and then a little stylus that tells us how much we remove, how much bone, and that's really dependent on how much bone there is that's worn out. So we put that on, we pin it, and then we start to create a little space where we can put a sagittal saw in, so we can cut the medial half of the tibia. That is the sagittal saw. It goes down, and we just want to ensure that it's orientated correctly, so that it doesn't impinge against the femoral condyle, so that the base plate doesn't impinge against the femoral condyle. So we need enough space there. It's literally just medial to the eminence. And then we do, through that cut, we do a horizontal saw cut, make sure that the MCL is protected. And we take out that little sliver of bone, and try to like gently take it out, because it's not easy to fill out bits and pieces of bone if there's not a lot of space there. So it's quite important to slowly, gently wiggle it out. And then you can actually see, that piece of bone has that antemedial wear. Unfortunately, it's now a little bit overexposed, but here's that piece of exposed bone there, and the cartilage in the back. Then we put a spacer in C. So here I noticed, the space is a little bit tight. I can't get an 8 millimeter in, so I'm taking a 7 millimeter spacer and seeing, okay, it goes in a lot better. So I know the prosthesis with the poly is 8 millimeters thick, so I need more space. And then I have to cut a little bit more with that to be able to get into the knee with inflection. Now I can get the 8 millimeter in quite nicely. Okay, now I focus and try to basically replicate that flexion gap to the extension gap. So this is a cutting guide that I can put in, that I need to ensure that I do in full extension, because that's orientated, the flexion extension of the component is determined by this block, and this block is sitting on the tibia. So depending on how I cut the tibia, I'll also cut the femur. So the whole system is based around the tibia cut. If the tibia is cut in various, automatically it'll also change the femoral cut. And so,
Prof, sorry.
Go ahead.
Sorry to interrupt. I just want to check with the other guys. I don't think we're seeing
the
slides.
Video. The slides aren't moving. The slides aren't
moving.
Yeah.
Okay.
Sorry, my brother.
Yeah, but can you see my cursor?
No, we're just seeing the first slide.
Why? So it took you like
stuck on steps.
Fuck it, man. So you let me talk for like 10 minutes before I get this. Well, fuck it, man. Then we can't do it.
We're using our imaginations.
Yeah, I can see that. Let me see if I can.
I was looking at the small pictures on the left side.
Okay, I can probably do it like now. You can see it.
Yes,
Yeah.
can see it now.
Okay. Good. I'm not going to go back now. Anyway. Okay, so we're basically doing a distal cut. Now, it's very much the same as for total knee. Now we have done the distal cut. Now we need to do the posterior cut. So for the posterior cut, I put the knee in 90 degrees, and then this is a little tool that goes into the knee so that we can do the chamfer cuts in the posterior cut. And it allows me to rotate a little bit, but again, most of the rotation is set by the tibia. And that's in a way tough, because if it cut the tibia wrong, then everything else is pretty much aligned in the wrong place. But it also, if the tibia is cut in a good alignment, it makes sure that the entire knee is aligned and it's also balanced. So it's not too tight or too loose in flexion or extension. So this is pretty much now the posterior cut of the femur, and then the chamfer cuts of the femur. Ashley's doing that, and then pretty much that was the cuts made. We've done the trial, and now we're putting cement in. And unfortunately, this is only a cemented implant, so we can't do uncemented implant for this company. We know that the uncemented implants actually are a little bit better in the registries. So we put quite a lot of, we try not to push a lot of cement into the back of the knee, because it's quite tricky to get it out. Push this down, and this is obviously now here, this is a little bit very gentle. There's a small hammer and just gentle little taps to get this thing down. And we scrape out the remaining cement, and then you put on the femoral component. Again, here it's quite fiddly to get it into that area past the knee. And then there's the liner, it goes in. into the knee, and then there's a little persuader. You can click it on, and basically that's now a fixed bearing cemented uni knee. And so a better outcomes are shown with a uncemented mobile bearing uni knee. So this is Smith & Nephew, and it's a new Smith & Nephew that they've bought over from another company, and it's not done as well as a uncemented mobile bearing uni knee from Oxford in the registries, but it's very much it's close to it, but it's not as good in terms of outcomes. And that's basically it, guys. So that's how you do a uni knee, or at least how it looks like. Is there any more questions?
Yeah, Prof, I've got a question. It's a very neat procedure. What are your thoughts on robotic assisted uni knees now?
After our last one, Peter. Fuck it. I still I couldn't actually sleep that night, because I was thinking, how is it possible that people do that? It's so fiddly, but there are quite a lot of good systems out now, and I think it's just a matter of time. And and obviously the learning curve, like in that one study, is we should actually do 6 robotic uni knees and then decide, because that's when the learning curve has plateaued, and that's when we basically could decide, well, is this something that we should continue with or not? I think we must still get a little bit more comfortable with it, and obviously there are certain ones that are based on a burr, which is very difficult to get into the posterior part of the knee with a burr. But there's also others that are doing it with a saw, and I guess specific to the uni knee, obviously there's the downsides of more time, pins in, more costs, but then I think specific to the uni knee, I think it's great because it actually gives you a lot more. It allows you to be a lot more precise in what you do, and I think in an operation where we don't do as often, I think it's worth to have another tool that makes it a little bit more precise. So I guess in someone that doesn't have the issues of finding patients, that doesn't probably matter for that person. But in someone that has got only a few cases, I think it's worthwhile. Did that answer your question, Peter? So yes, we're going to do more, but I don't know when.
Yes.
I have to first. Anything else, guys? 9:30. That's like perfect. 1.5 hours, perfect timing. I think we must all go to our families and enjoy the evening. Unless someone has a burning question.
I'm sorry, Prof, it's Francis.
Francis, you don't have a family.